Okay, thank you everyone for being here. I'd like to welcome you to the June 7 HONSAC meeting. Today we are proud to have a guest speaker who will be talking with us today about the telehealth and telemedicine at the Pacific Regional Medical Command. Our guest speaker today is retired Colonel Suzanne D. Martin, who is the Regional Telehealth Director for the Pacific Regional Medical Command at the Tripler Army Medical Center. She's responsible for the management, oversight, and execution of the telehealth program and for supporting telehealth applications for Tripler and the Pacific Regional Medical Command. Anyway, it's a great honor to have her here today. Please join me in welcoming Suzanne Martin.
Thank you. Aloha. The Pacific Regional Medical Command is one of 5 Army medical commands. Can you hear me okay? Maybe you could bring this up. Is it better? Maybe that's not. How's that? Is that better? Well, there's one here and one there. So.
He doesn't want it to be in your area, so it's
Okay.
blocking.
I'll try to talk a little bit louder. Can you hear me okay now? Okay. All right. Pacific Regional Medical Command is one of 5 Army medical commands around the world. And it's based here in Hawaii, and it's co-located with Tripler Army Medical Center, which is one of our military treatment facilities under the Pacific Regional Medical Command. We have about 171,000 military beneficiaries across the Pacific in greater than 40 countries. There's 337,000 DoD eligible patients or population here in the Pacific region, and an additional 128,000 VA beneficiaries. While the focus of our telehealth programs in the Pacific region are right here in our area of operations, we also support some of the other regional medical commands on the mainland. We have a lot of specialty care services at Tripler that we can share, and we estimate that about 150,000 beneficiaries per year benefit from the specialty care services that we offer at Tripler. And we have a lot of specialty care because we have a lot of training programs. We have 21 training programs. No military briefing would be complete without a slide that totally baffles you. So this is the Army Medicine Strategy Map, and this is linked to our balanced scorecard. And I just show you this to show you that there's a lot of places that guide our strategic planning where we can fit telehealth in. And if you look in that middle circle, here and look at 7.0, it says improve access and continuity. I think that's one of the places we can make a huge impact with telehealth. And also if you look at the bottom at R 1.0, talks about optimizing resources. So we really have a good mission for our telehealth programs out in the Pacific. This is what I plan to cover today. Okay, here are the telehealth services that we offer out here, and I've color-coded them for you into different categories. What you see at the top in the purplish color, these are all our telebehavioral health telehealth programs. We have some behavioral modification groups that you see in the teal. Our tele-traumatic brain injury programs are in the gray. the telecritical care in green, our asynchronous applications in black, and teleeducation at the bottom there in the red. So we have a lot of programs. They're not all huge programs, but we do have a lot of services that we can offer, and hopefully we'll be able to expand these in the years ahead. In the Pacific area, we reach out to Department of Defense facilities in a number of countries and island nations. And the services are all provided at the hub here at Tripler Army Medical Center by the providers that belong to our organization. In Hawaii, we have telehealth suites at all the Army medical clinics. And we also have telehealth capabilities in the National Guard facilities that are on Maui and in Hilo. The services that we offer at each of the locations that I'll run through are in the boxes there. You might wonder, why are we doing this on Oahu? I mean, it makes sense for the neighbor islands, but why Oahu? And the reason is because we actually can save the beneficiaries or the soldiers and their family members time by not making them drive up to Tripler Hill and fight the parking. If you've ever been up on the hill, you know we have a huge parking problem up there. So we save them some time, but we can also augment the services that we offer face-to-face. So, for example, if you have a behavioral health clinic and they're at capacity, we have telebehavioral health providers, and we can have those patients go to one of the telehealth suites and actually get care from one of our telebehavioral health providers. We also have telehealth suites, a telehealth suite in American Samoa. And this one is co-located with the VA outpatient clinic there, and it services reservists and retirees on the island of Samoa. We'll talk a little bit more about that. Throughout the rest of the Pacific, we reach out to active duty Army, Navy, Air Force, Marines, and their family members, and in some instances, we provide services to reservists and National Guard that are out in the Pacific. So here you can see the services and the locations for Japan. We also support Okinawa. Korea, and we're expanding right now across the Korea Peninsula with some of our telebehavioral health services. In Guam, this is one of the places where we're actually able to reach out to the Guam National Guard and the Army Reservists that are actually assigned to the command here in Honolulu. And we even provide services to the other regional medical commands on the mainland. So if the military treatment facilities need some augmentation, primarily in the behavioral health arena, and also the Army recruiting stations on the mainland, we can do behavioral health evaluations and treatments for the soldiers that are at those locations.
So do they go to a certain place to tap into the system, or can they do it from home? Or?
No, we do not do anything from home currently. That's something that we're exploring, but unlike the VA, which is already going into the homes, on the military side, none of the military services are able to reach out to the soldiers or service members in their homes.
Someone at Pearl who wanted to get help from Tripler, they would go to a Pearl clinic?
Yes, yes. They would go there where they could get behind a VTC or one of the other technologies that we use. Okay, much of the savings that we realize with our telehealth programs is by avoiding the costs for travel. So if we can treat that service member or the family member wherever they're based, then they don't have to travel to Tripler or elsewhere for care. So you can see with the green bars what we've done with avoiding cost. And then you can also see with the blue line that we are expanding our services. So this is a real success story. Much of the growth, of course, is in the telebehavioral health services. And you can see that on this slide in the chartreuse kind of color there. That we started most of our telebehavioral health programs around March of last year, so we've grown them quite a bit. Our telehealth staffing is still fairly lean. So in my telehealth office, there's myself, and then I have 4 full-time equivalents that assist me with oversight of the telehealth programs. The majority of the telehealth staff that we have, the dedicated staff, are in the telebehavioral health programs and the teletraumatic brain injury programs. And that makes sense because we've got recent combat experience and we have service members returning with issues in those areas. And so that's where we're getting the most funding from the DoD level and the most interest. Here you can see the functions of my regional telehealth office. We provide umbrella oversight for the telehealth programs. Of course, we're a little more hands-on with the telebehavioral health and the teletraumatic brain injury functions, of course, because of the greater focus from the DoD level and in response to the injuries from combat. And in the telebehavioral health arena, we actually have a dedicated 12-provider cell, and they're totally dedicated to telebehavioral health. They have a support staff that assists with reaching out to patients all over the world. They provide a full spectrum of outpatient behavioral health services. And the technologies that they're using are, we have VTC technology, we have a technology called MOVI or Jabber, which is a software that enables an internet protocol connection between 2 different locations. And then we also have a secure Skype-like product called Defense Connect Online. So that's what we use to reach out to the patients. And the providers all have these technologies in their office, so they can sit right in their office and they can provide services to the patient at the distant locations. We call the telebehavioral health cell a surge support cell because what they do is they fill gaps. They fill gaps when we don't have services in certain locations, or they fill gaps when we don't have enough providers in locations, and they can provide those services when and where they're needed. We also have child and adolescent telebehavioral health services. We call it the CATS program. This model is a little bit different from the adult telebehavioral health in that there's actually providers that are embedded at the patient location. So they're perhaps a licensed clinical social worker or a psychologist that's at the patient site. They can see the patients face to face, and if they need to consult with the psychiatrist, the child psychiatrist back at Tripler, then they can connect the patient to that psychiatrist using telehealth capabilities. And if you all know anything about our school behavioral health program, this is one of the things that we do with our CATS program, that we can actually link the children that are in the schools on the military bases with the providers that are at Tripler. And it can make a significant improvement in access to care. What this is the School Behavioral Health Program. So the SBHT there is School Behavioral Health Team, and CAPS means Child and Adolescent Psychiatric Service, and that's the face-to-face psychiatric services at Tripler. So you can see that the time that you pull the child or the patient away in order to take them up to a face-to-face visit is great when you compare it to what you can do by having that LCSW or that psychologist at the school linking that child to services at Tripler. Our traumatic brain injury services, also referred to as the concussion clinic, is credited with really doing some of the early establishment of our current VTC infrastructure. And of course, this was in response to concerns about the traumatic brain injuries that were coming out of combat. As you can see, it's a multidisciplinary team. They do face-to-face services up at Tripler, but by having the telehealth capabilities, they can reach out to other places where they don't have specialists like neuropsychologists or maybe they don't have psychiatrists or other folks that specialize in concussive injuries. And they have a real success story in American Samoa. That clinic that we have out there is actually a tele-TBI clinic, although we do also some telebehavioral health surge support services there as well. But American Samoa, if you didn't know, has one of the highest percentages of population that have gone into military service compared with any U.S. state. And many of them have had recent combat experience with Operation Iraqi Freedom and with the current hostilities in Afghanistan. American Samoa is 2,600 miles away from Hawaii, and we are the closest military medical specialty center that can help with treating their beneficiaries. And of course, we can save a significant amount of money if we don't have to have the patients travel for care. You know, just coming to Hawaii for one time is like $3,500. So we can make a significant impact here. Lean, healthy lifestyle. If you look on the right there, you can see what the L's, the E's, the A's, and the N's mean. This is a program that reaches out with some group treatment, education, and support. It focuses on nutrition and exercise. We can use this program as a standalone, or they also use it in conjunction with our bariatric surgery program, so they can do some of the pre-work with the patients that are going to come for bariatric surgery, and they can also do some aftercare after they've returned home. And then they don't have to spend so much time on Oahu if they've come here or been evacuated here just for that surgery. Our telecritical care unit may be the unit that some of you are more familiar with. It was the first major synchronous telehealth program that we had at Tripler. We don't typically do 24/7, 365 monitoring with this unit, but what we can do is we can make available the intensivists that we have on staff at Tripler, so that in the ICUs that are out in the Pacific, if they have gaps in coverage, if they're only one deep and the provider needs to go on vacation or is sick or something, it allows us to help out to continue treatment in their ICU units. And it also enables us to share a robust medical and surgical specialty consultation capability with them that they might not otherwise have. The telecritical care unit started in 2001, and when we first stood it up, it was an EICU product, which was a commercial product. Last year, we actually converted it to VTC, standard VTC technology, but the connection that we have from the Tripler ICUs to the ones out in the Pacific is a dedicated line. So there's more integrity there, which is important when you're talking about critical care. We're now across the Pacific at 4 locations, Guam, Korea, Yokosuka, and Okinawa. Back in 2009, they looked at 500 consults over a 7-month time period, and they determined, going case by case, that over that time period that they were able to avoid evacuating 4 patients to Tripler. If you know anything about evacuating medical patients, if you evacuate an ICU patient, it's hugely expensive. So when you look at an ability over that time frame, they saved almost $800,000 just by avoiding evacuating those 4 patients. And if you extrapolate that over a 5-year time period, we're talking about almost $4 million that you can save. Pacific Asynchronous Telehealth is actually one of the longest standing telehealth programs we have, which started back in 2000. It is an asynchronous product, which means that the provider is not seeing the patient directly. They're getting a consultation request in from a provider out in the Pacific that says, I have a patient, this is how they present, and can you help me with some specialty consultation? So we're supporting pediatric and adult medical and surgical for all the DoD personnel out there in the Pacific, and we even reach out to the ships that are out in the Pacific as well. So the specialist at Tripler reviews the case, which they receive over a secure website, and they respond to the provider that's at the patient site. And they can say, here's how I recommend you treat the patient, or they could say, you're not going to be able to do it at your location. I recommend you evacuate the patient. They can even coordinate within that application that air evacuation back to Tripler. You can upload any kind of media to your consultation requests. And you see heart sounds there. Our pediatric cardiologist developed a product so that he can actually listen to recording of heart sounds of pediatric patients out in the Pacific and tell whether or not it's a benign murmur or whether or not they need to be evacuated. Maybe they'll need surgical intervention. There's also an application called Aloha. And this allows us to record graduate medical education sessions for folks to view later on. As you can see, the volume for Pacific Asynchronous Telehealth is growing as well, and there's been a 20% increase per year since 2004, which is a real good news story. This is a real, low cost investment for a lot of payoff. We have a number of programs under development. For example, let me talk a little bit about the telepain that you see there with the acronym ECHO in parentheses after it. ECHO means Extension for Community Healthcare Outcomes. And this was a program that was developed at the University of New Mexico, and they developed it actually to reach out to patients throughout the state that had hepatitis C. And what ECHO does is it shares the expertise of a multidisciplinary group of providers with patient locations where they may only have a primary care provider or they don't have the depth of specialty care that they have at the hub. So in our integrated pain management center, what we hope to do is have weekly or monthly sessions where the providers, not the patients, but the providers call into a conference. They get some continuing medical education. The multidisciplinary team helps them to learn more about how they can better treat their own pain patients without having to evacuate them. They earn continuing medical education credit, and they also have an opportunity to present cases and get specific feedback on what they might do with that particular case. And then the patients won't have to be evacuated is what we're hoping. We have a number of challenges with telehealth programs. You know, it's not as simple as turning on a VTC at the provider site and turning on a VTC at the patient site. There's a lot of stuff that goes on in the background as well. With credentialing and privileging, not only do the providers have to be credentialed and privileged at Tripler, where the hub is, but they also have to be privileged where the patient is. We have a system, an automated system that does credentialing and privileging or shares information for credentialing and privileging across the whole Department of Defense military health system. But I will tell you, it's not seamless. And this is probably one of the things that takes the most time when you're gearing up for a telehealth session, because you can't do any face-to-face session or direct care session without having that provider privileged at the patient location. Telebehavioral health scheduling, the third one on the list there. When you schedule a telebehavioral health session, it's not just scheduling the provider and the patient. Luckily, our behavioral health providers usually have equipment in their own rooms. But if they didn't, you'd have to schedule the provider, schedule a room and equipment, schedule the patient, schedule a room and equipment. And oh, by the way, the patients, although we have an automated scheduling system that's built into our patient registration and our electronic health record, we're all on different platforms. So the platform here in Oahu services the clinics here in Oahu, Army, Navy, Air Force, Marine. But when you go out to Japan or Okinawa or whatever, they're on different platforms. So the patient has to be registered before you can actually schedule them. And then you need to, so we're doing stubby pencil drill with a lot of our scheduling, which we hope one day we won't have to do that. And then you see CHCS, ALTA interoperability right below that. CHCS and ALTA are electronic health records. And even though everybody in the military health system uses them, all the CHCS platforms are different, like I said, and it's not seamless. There's a delay a lot. You know, I can put an ALTA note, no, I can, I'm not a provider, but they can put an ALTA note in here in Hawaii, but it may be delayed before it actually shows up where the patient's provider, their primary care provider in Okinawa or Japan or Korea might be able to see it. So we do have some hurdles that we have to work with, but all in all, we're making the best of what we have. I kind of went through this pretty quickly, kind of a broad brush. I thank you for your attention, but I'm hoping you have some questions, and I'd love to be able to field them now. Yes?
Do you have this on any of the ships?
The only thing that we actually do with the ships right now is the Pacific asynchronous telehealth. And when they come into range so that they can get internet access, then they can actually send a request for consultation. But, you know, of course, if they're out of range or whatever, there's not much that they can do there. But we help them out where we can and where they request. And they also do a lot of, they'll call back to different ports where they have more definitive care, and they may get some recommendations on treatment that way as well.
What do you lose? I mean, it's face-to-face, but it's not face-to-face. So, I mean, obviously it's efficient and effective, but do you lose anything? It's quasi-face-to-face, right? Say with behavioral health. Mm-hmm. I mean, it's not like sitting across the table with someone.
Actually, it can be very close to that. I mean, there's, like, if you use the Skype-like technology, you know there's a delay there. And the providers are taught, you know, how to deal with the delay. You know, don't talk on top of your patient. You know, make sure that they're done talking before you speak. So they know how to handle some of those delays. The patients are also told that before they'll go into a session as well. Interestingly, though, you know, behavioral health is something where there's a little bit of stigma about it. So if the patients can distance themselves from the providers a little bit, some of them like it more than they like face-to-face. So probably we get more challenges with providers, not the telebehavioral health providers, because that's what they were hired for. But, you know, when you're trying to get providers in the distant locations to make referrals or to use telehealth with their patients, they probably have a harder time of it than the patients themselves. I mean, you think about the population that we're dealing with. You know, the military population is a young population. They're used to Skype. They're used to their phones. You know, so it's quite, you know, the satisfaction with it is quite high. Yes.
You've got on the list nutrition. Is that medical nutrition therapy or just general nutrition education?
Some of both. I mean, we're not talking about what is it called? We're not talking about, you know, like IV or tube feeding or anything like that, but yes, absolutely, and that's what that's geared toward. I mean, the LEAN program can support folks that are just trying to lose weight. It can also support folks that have a medical reason for needing to lose weight or why they can't lose weight. So they actually talk about all of those different things in their...
So is it primarily focused around weight?
Primarily. But, you know, some of the tenets that they teach there can be used for anything where you're trying to change behavior and change a habit. In addition to the LEAN, we also have a tobacco cessation program. So you use some of the same techniques when you're talking about how to change somebody's behaviors and habits. Yes?
You know, when you're a patient and you go into an exam room, are you ever there just by yourself, connected with a practitioner off-site, or is there always some kind of chaperone with you?
Okay, that's a good question. With telebehavioral health, the patient is by themselves in the room, but we have somebody there to assist in case we need them. I mean, the model that's easiest for us to use is that, you know, outside the telehealth suite, we have a telepresenter, we call them, and they have a pager. And if the provider needs them to intervene, they page them, and then they can intervene. But anytime you have a telehealth session going on, the patient has to consent to anybody else being in the room or overhearing. For example, if I was the provider and I had somebody sitting over here that you couldn't see, I have to get you to consent to have that person in the room. So most of the time we don't have somebody physically in the room. Now, if you're doing something on the medical or surgical side, you may have a provider in the room with the patient that's helping with some of the physical exam, for example. And that's one of the things we're talking about doing with the telepain, that they would actually have a provider or a medical extender of some sort with the patient, so they could relay back to the provider that's consulting via VTC, range of motion, things like that. Yes?
Quality assurance, or for any other purpose, just as a learning tool, I guess. Is there any consideration given to recording these sessions? Maybe not for behavioral health, but for some medical.
Yes, we can record, but again, you have to get the patient's consent to do the recording. We don't do a whole lot of recording of sessions.
Are there any applications or policies regarding like mobile devices for telehealth?
Actually, that's one of the things that I am dying to get into, what we call mHealth. Is that what you're talking about, where you use like smartphone technology and things like that? Right now, the Army is doing some of those things, but it's at the subclinical level because we're not allowed to reach out to the patient in their home and provide care. But we can do, you know, interact with them, you know, push them educational things, get their feedback to maybe a nurse case manager about how are you doing. So that's one of the things that I really want to explore with our programs out here. So I'm hoping that by the end of this calendar year, we'll have some kind of mHealth program that we're using. The Army's doing it already on the mainland. Well, thank you very much. It was a pleasure joining you today. And if anybody has any follow-up questions, Karen has my contact information, or I'd be happy to give you a card.
It's on the bottom of your.
Yes, send me an email.
You can see it.
Thank you.